KSSI for giving me this opportunity, especially Dr. Gautam Zaveri and Kritish for coordinating for this ASSI video journal. I am going to share few of the articles which have actually changed my practice on spinal deformity, both in pediatric spine and aging spine. I take this opportunity to thank my mentor, teacher, philosopher and guide, who has transformed my life tremendously. As you all know, a good teacher teaches, a better teacher makes you think, but a great teacher always inspires. It's my great privilege to work with him and learn the basics of research. So coming to research that changed in my practice, there's two areas, the two important areas in the deformity which I'm going to cover in this short lecture. One is on the pediatric deformity, other one is adult spinal deformity. We all know that kyphotic deformity in children is a very devastating disorder, and it increases with the age and till the growth, skeletal maturity happens, and tremendously compromises the person's quality of life and also endangers the neurological structures and causing neurological deficits. So to correct these deformities, the spinal level, cord level spinal shortening osteotomies have been proposed. In the adults, the similar kind of deformities can be easily managed with pedicle subtraction osteotomies and posterior column shortening, giving rise to a perfect sagittal profile to these patients. But the most feared complication of these procedures is a neurological deficit. So once the posterior column gets shortened, there is a high chance that the spinal cord gets kinked, and that causes the neurological deficit. And different authors have quoted different safe deformity angles so that the neurological deficits can be avoided. But these are all anecdotal recommendations. Out of their experience, the approximate level of osteotomy which is safely done without neurological deficits were mentioned. But a lot of literature is from the lumbar osteotomies rather than the cord level osteotomies. But knowing these angles really doesn't help us in real situations while operating, how much we are correcting exactly in terms of angles from 35 to 40. The difference between 40 to 50 will be sometimes a catastrophic event, but that can't be assessed intraoperatively. So this is the article which have scientifically gone into the risks of acute shortening in spinal cord. This is by Kawahara, Japanese group, which have done a tremendous work on this particular surgery. And this is what I am going to discuss in detail. So these researchers have actually used dog's spine, and they have done spondylectomy, and they have taken one vertebral body and put screws above and below and try to compress the spine. So while compressing the spine, they observed the deformity of the spinal cord anatomically. They call it as a morphological morphometric analysis. At the same time, they measured the blood flow in the anterospinal arteries and also evoked potentials from the spinal cord. So this is the experimental study. They have taken out the spondylectomy of 13th thoracic vertebra in the dog, and how they have done. After taking out the 13th vertebral body, when they shortened the spine by 5 millimeters, they noticed a kink of the spine, but not very significant. But when the shortening increased to 10 millimeters, you can see the angle of the spinal cord gets altered. And it crosses the 15 millimeters, and then you can see the buckling of the spinal cord happening. And in 20 millimeters of shortening, where that corresponds to one vertebral segment. So you can see the acute kinking of the spinal cord. This is what endangers the spine while performing the osteotomy, and that leads to neurological deficits. So they have proposed safe limits for these osteotomies or shortenings of the spine. So this is also, they also observed the morphological change in how the spinal cord kinks, and this is external appearance, and this is after taking the cross sections of the spine. They measured how much of the cord is being actually deformed and how much of the dura is actually deformed. You can see the dura deformation happening from the 10 millimeters itself, and you can see severe acute kinking of the spinal cord happening at 20 millimeters of shortening. When we do cross-sectional dissection of the same specimens, you can see how much of the tracts are getting deformed. They also observed the anterior spinal artery. You can see it in the controls, you can see the straight anterior spinal artery. And when the compression increases by 5 millimeters, it becomes slightly tortuous. In 10 millimeters also it becomes tortuous, but in 15 and 20 millimeters, it causes acute shortening, kinking, and compression of the spinal arteries. So they concluded that the spondylectomy of one vertebral body happens in 3 phases. That means in phase 1, that is a safety range, the first 1/3 of shortening, there is no buckling of dural sac and neither the buckling of spinal cord. In phase 2, which is the warning range, that is from 1/3 to 2/3 of a vertebral body, they notice the buckling of the dura only, but not the spinal cord. So we can see only the CSF column and the dural sac buckles, but the cord is not deformed. But in the phase, that's phase 3, which is the dangerous range, greater than 2/3 of vertebral body shortening, you can see buckling of the dura at the same time spinal cord deformity as well. This is the basis of spinal cord shortenings, and then different kinds of osteotomies being proposed, closed open wedging osteotomies, and how to maintain the hinge in the vertebral osteotomies when we are correcting from the posterior without causing kinking of the spinal cord, and you can lengthen the anterior column so that the spinal cord deformation can be avoided. So to follow up on these things, this paper by the initial paper by Kawahara was published in 2005, and in 2007, these researchers from Turkey, Dr. Amelidaroglu from Turkey has actually studied the morphological effects of acute shortening and kinking and sliding in response to spinal nerves, but slightly differently than what they have done with the Kawahara's morphometric analysis. This is what we have learned till now, that there is a kinking of the spinal cord which happens after complete shortening of the spinal cord. So what Almedarolo have done is they have also noticed the same thing in acute kinking of the spinal cord after acute shortening. But once they extended the laminectomy of the same thing without increasing the lengthening of the spinal cord, keeping the same shortening, they extended the laminectomy of lamina above and off lamina below. So you can see the significant reduction in the kinking of the spinal cord. When they are done 2 laminates, so 1 lamina above and 1 lamina below, in addition to the laminectomy at the site of shortening, you can see the complete restoration of the spinal cord without any kinking. So this has got tremendous clinical value in the sense that acute shortening, which causes spinal cord kinking, can be prevented or avoided by doing a sufficient laminectomy at above and below the levels of shortening. So this is being practiced now, and whenever you see there is a kinking of the spinal cord, whenever we do an osteotomy, we try to extend the laminectomy to make it safer. So there's the same thing has been documented even in the pediatric spinal populations by Lenke group, and they have noticed whenever they are doing a PS4, they had noticed in 9 cases there was a drop of signals while performing the closure of the PS4, and what they have done is to release the correction and further decompression of the lamina. So that's where the safe spinal cord shortening can be performed. So this we have, this has transformed into practice. We adapted this in the practice in performing the pediatric spinal osteotomies. You can see this patient has got an acute spinal deformity of 133 degrees, which was corrected to 65 degrees with an angle of osteotomy angle of 68 degrees, and we shortened it to 21 millimeters of shortening. So significant amount of shortening without any neurological deficit by following the principles of correcting, doing an osteotomy and doing an extensive laminectomy. At the same time, even the same thing cannot be applied to the adults, but there is something else also happening in the pediatric spine, which makes the spinal cord shortening safer in children. So we wanted to study that in detail. Is the pediatric spine is more accommodative for spinal cord shortening. We hypothesize that pediatric spine being more flexible, it can accommodate spinal deformation better, And to test this, we have done the radiological analysis of distribution of correction after osteotomy. You can see this is, so in this series of cases, we have measured the amount of osteotomy performed and the correction provided by the osteotomy, and also the correction provided by the segments adjacent to the level of osteotomy. Whereas the osteotomy has provided 49 degrees of correction, the adjacent segments all put together, you can see from the apex above and apex below, if you calculate the amount of correction what is achieved in the adjacent segment, it adds up to another 45 degrees of correction without much of osteotomy here. So this is attributed to the flexibility of the pediatric spine, which makes the deformation of the spinal cord much safer as compared to the adults. Even in the adults, the lumbar is safer because of the flexibility of the lumbar spine of intervertebral discs, but thoracic spine is being rigid. The thoracic and thoracolumbar corrections are quite, they're not, the window of safety is very less in thoracic spine because of its rigidity. But this is may not be true in pediatric population. We also measured the amount of translation happening in these patients from the apical level of vertebral body translations, and there is also significant amount of rotation being corrected at the level of osteotomy, not only at the level of osteotomy but also adjacent segments are getting corrected better to give a decent sagittal profile correction. The osteotomy height also measured using this formula, and the amount of shortening what we achieved is there is 21 millimeters of shortening and 2.3 degrees per millimeter of shortening, giving a widely distributed correction not only at the apex of the osteotomy, at the site of osteotomy, but also at the adjacent segments. So we have noticed that the adjacent segments not only translate, they rotate and they accommodate to the corrected shape, so and giving rise to a safer correction in the pediatric population. So this is one of the research which has translated into our clinical practice, and we were performing these osteotomies quite safely nowadays, and we were able to avoid the vertebral column resections in pediatric population using this approach. So second group of patients we have, which we are interested is the aging spine with adult spinal deformity. So we keep seeing these patients of coronal and sagittal decompensation in the adult age group. So the work which I am going to describe is the monumental work by Frank Schwab. So in identifying these sagittal parameters and the radiological parameters which are actually causing clinical symptoms these patients. So he has done a tremendous work on adult spinal deformity in identifying the sagittal profile maintenance and also the translations and the obliquity of the vertebral bodies. His initial work is based on this concept where he tries to analyze the adult spinal curvature, and corrections have been proposed basing on the central sacral, vertical central sacral line, and also the obliquity of L3, the obliquity of L4, and the amount of lateral lesthesis. These were the radiological parameters which I have used, and he found that these radiological parameters have got a lot of clinical impact of the patients. And then he tried to address these factors while doing the corrections. During the process, he has proposed a classification. This is the clinical impact classification of adult scoliosis classification, the first classification of its kind, where he tried to analyze and cover the different aspects of radiological deformity of the spine. So he divided the radiological deformities into type 1 to 5, basing on the thoracic or upper thoracic, lower thoracic, thoracolumbar and lumbar curves, and the lumbar lordosis modifier being added depending on how much of the lordosis is being modified. So less than 40 and more than 40 is the one which has decided as a criteria, and also subluxation. The subluxation of the vertebral bodies is also picked up effectively from 7 millimeters or less than 7 millimeters of subluxation. And basing on this concept, he developed a classification and proposed different kinds of surgeries in these patients and osteotomies. So during the later years, when the sagittal profile has been extensively studied, then we came to know that there are different kinds of patients with the low pelvic incidence and high pelvic incidence, which is identification marker for the particular patients. And we also understood the amount of compensative mechanisms which help to replace the head over the pelvis in these patients with sagittal imbalance. And additional compensatory mechanisms at the hip and knee were also measured, and the amount of pelvic rotation and tilt which causes the fatigue has been proposed. So this is the major work of Frank Schwab, where he identified the relation between the spine and the pelvis, and PEI minus LL, the pelvic incidence minus lumbar lordosis mismatch. This is the greatest concept proposed by Frank Schwab, and basing on these concepts, different kinds of surgical surgeries have been proposed, and he kept it as a threshold of less than 10 degrees. The mismatch within the 10 degrees patients can tolerate, and if it is more than 10 degrees, we need to correct it within that range to get a adequate sagittal profile. And he found that this has got a high clinical impact, and this mismatch is correlated with SRS questionnaires appearance, activity domain, and the total domains, and Oswestry Disability Index of walk and stand, and SF12. So these are the parameters. The pelvic PA minus LL mismatch is the parameter which causes patients the clinical problem. So once this is restored, the patients can have a decent pain relief of correction of the sagittal profile. So this has been adapted by Scoliosis Research Society, and both put together they developed a classification on Scoliosis Research, SRS Schwab's classification adult spinal deformity. This is the most widely used classifications as of now while managing the patients with adult spinal deformity. So wherein they included the coronal curve types and sagittal modifiers. Coronal curve types were thoracic, thoracolumbar, double curve, and the no coronal deformity as a coronal curve type. And sagittal modifiers, the parameters which were considered as PA minus LL mismatch, which is the work of Frank Schwab. And the global alignment was also included, and the pelvic tilt was also included in the parameters. Basing on this, different kinds of surgeries and restorative procedures have been proposed, and the tremendous work has been done basing on this classification and to correct the spine and give the patient a pain relief proposal. So this is one of our case where we followed these principles and try to correct the sagittal mismatch, sagittal profile correction with a pedicle subtraction osteotomy at the lumbar level to restore the pelvic balance of sagittal profile to get a very good sagittal profile to reduce the fatigue of the patients. So while going through these procedures, the now concept of this classification being applied to the wide variety of adult spinal deformities is becoming a big problem, because this is basically predominantly a radiological classification. But these patients come to us for different reasons. They come to us for cosmetic skeletal deformity, which is a spinal deformity, and pain, neurological claudication, sometimes neurological deficits, they are associated with so many comorbid conditions. So each patient itself is a subset of multiple factors put together. If you can see, this patient present to us only with the back pain, the similar amount of deformity, but this patient had along with back pain, leg pain also. So these patients require, the patients with leg pain require a procedure which decompresses the spine in addition to the correction of the deformity. So the radiological classification cannot differentiate these things. And again, if you see these two examples of the patients, the first patient is severely osteoporotic. So whatever amount of correction which you are going to plan in these patients may not be successful. And this patient has got a very good bone stock, and he can tolerate good amount of corrections and osteotomies and realignment procedures very well. So again, the radiological classification cannot pick it up, and also patients sometimes they're obese and sedentary, and this patient is very active and young. These two patients cannot be compared, and the same surgical procedures cannot be put advocated for the both the patients. Similarly, these patients are very fragile and multiple comorbidities. Even though this patient is very elderly, but she is quite healthy in terms of her cardiovascular status, her frailty score. She has got a very good social support, which can help us to decide on the type of procedures which we are going to suggest her. So this is a good social support. Family with no social support also matters in these adult spinal deformity patients in a very elderly. These are the 4 cases of Frank Schwab's. These 4 cases of adult spinal deformity. We classified them according to Frank Schwab classification. You can see all these 4 patients, they fall into the same category of Frank Schwab as far as Schwab's classification, where the deformity is thoracolumbar, and the PI minus LL is positive, mismatch is positive, and SVA is positive, and pelvic tilt is positive. So this, but these patients, if you see, the first patient has got a severe stenosis of L4-5, so he requires a thorough decompression, and the second patient is extremely obese, and the third patient is osteoporotic, and you can see there is one vertebroplasty already being done on this patient, and other patient is 85 years, diabetic and hypertension, post CABC with multiple comorbidities. Even though the radiologically all patients are same according to radiological classification, but they are all different when you see them holistically, comprehensively as a patient. So we have analyzed these factors where we are missing the link of patient and the radiology. So we published this in Asian Spine Journal, where what is ideal adult spinal deformity classification system should consist of. We reviewed the factors, various factors, and identified what are all the factors which can really influence these patients, like curve type, sagittal modifiers, lumbar modifiers, spinopelvic parameters, age, gender, back pain, leg pain, duration, obesity, osteoporosis, hypertension, smoking, so on and so forth. So you can see that only a few classifications have actually addressed the clinical parameters, especially by MaxAV, but rest all have not addressed anything about the major factors which decide the treatment management protocol in these patients. So then we have analyzed the available classification systems on adult spinal deformity using this systematic review, and found out that SRS Frank Schwab's classification was the most commonly used classification, but none of the classifications were clinical in nature, all are radiological in nature. The radiological classification holds good in treating adolescent idiopathic scoliosis because the patient comes for cosmetic deformity, where the radiological parameters are quite enough to arrest the progression of the disease and correct the curve. But in adult spinal deformity, we need to have the radiological parameters also. So we come up with a kind of a proposal where the radiological type, clinical modifiers, and comorbids as a 3 domains where we need to assess these patients. And we applied this from as Spine India. I being a research officer for this, so we applied for this for the Spine Global Research Grant, which was initiated in 2016. Across the 45 applications, 3 were selected, and we are one of the people who got awarded this research. And then we presented this in the consortium. So the concept of this classification, and then the brainstorming was done with a knowledge forum. Spine Knowledge Forum has joined hands to develop this classification, and the legends of spine surgery across the world, they come together to put their minds to refine this classification. And this is the core study group on developing a profile for the patients with adult spinal deformity. And we use this SRS score outcome set of different parameters which were important uh, in the management of adult scoliosis. And we run a Delphi process, which is a three round Delphi process, with the fourth round of face-to-face Delphi process was conducted. For the Delphi process, online applications for the experts were called for. We have 175 respondents across the globe, and 51 were selected based on their experience, publications, and regional distribution. And there was one face-to-face meeting done at Toronto, which was chaired by Professor Larry Lenke and Marinus Dick Kluwer. These are all the faculty, these experts who have participated in the process, and the voting for all the factors to be included in the classification was done with a minimum of 80% agreement was taken as a criteria. And this is what we have developed as a proposal. So this eospine adult spinal deformity patient profile was developed with the concept of extension of Frank Schwab's SRS Schwab's classification. So we included the domains like general health status of the patient, where the age, gender, social support, comorbidities were there, and spine specific status like functional ability, back pain, leg pain, and SRS questionnaire, expectations of the patient, and previous surgery. Neurological status was also included in the classification. And imaging wise, radiographs and also MRI. MRI has been included, one of the major factors in the classification. None of the adult spinal deformity patients undergo surgery without having an MRI. So radiographs were thoroughly analyzed for coronal planes and sagittal planes, and the type of the deformity according to Abyss classification of etiology was done. So we propose to look beyond the radiographs and not only cob angles, lumbar lordosis, pelvic tilt, sagittal slopes, mismatch, osteotomy angles. The clinical factors of the patients are also very important in deciding these things in adult spinal deformity. This research extension of Schwab's classification is what has come into our practice. I once again thank my mentor, Dr. Rajshekharan, for inspiring all of us to do